So I'll be talking in favor of toric IOL in keratoconus with cataract. So little bit of introduction. As we all know, keratoconus is a non-inflammatory corneal condition with onset commonly in early adulthood, which gradually progresses and often stabilizes later in life. The corneal astigmatism in keratoconus adds to further loss of vision when one develops a cataract, and we also know that in these patients, the cataract develops earlier than people who do not have keratoconus. And most of these patients are myopic, which increases their risk for cataract formation. And the magnitude of astigmatism in keratoconic eyes can be quite prominent and high. And eyes with keratoconus may have significant regular or irregular astigmatism. And toric IOLs are beneficial for eyes with high pre-op regular corneal astigmatism. And assessment of progression of the disease is very, very important before considering for a toric IOL. So this is the treatment algorithm for keratoconus with cataract. If we have a patient with stable keratoconus with cataract and he has a good tolerance with contact lens, then we can consider for monofocal IOL if the patient has cataract and he can continue the contact lens post-surgery. But if the patient has poor contact lens tolerance and he has mild to moderate keratoconus and keratometry is repeatable on topographer, then we can consider for toric IOL. Or if the patient is having irregular Myers on topography, then we have to consider for corneal regularization procedure, and we can also consider for ICRS prior to cataract surgery with monofocal or toric IOLs. In cases of severe keratoconus, obviously we have to go for corneal-based surgeries in the form of triple procedure, which includes penetrating keratoplasty with cataract surgery, or we can also go for sequential cataract surgeries. In that we can perform ICRS, DALC, or PK, which is followed by cataract surgery. Coming to RGP versus toric IOL, in cases of RGP, the main factor is the cost factor, because there is a high cost for RGP lenses as compared to toric IOLs, and maintenance is also an important factor. And these contact lenses are usually not covered by insurance companies, so there is an economic burden to our Indian patients. And we also have a lot of side effects by using these contact lenses in the form of concretions, blepharoptosis, and a few patients do have allergies with contact lenses because of the preservatives and solutions being used in that. Some do present with allergic conjunctivitis, superior limbic keratoconjunctivitis, giant papillary conjunctivitis, and risk of infection is always there with the use of these lenses. High association of atopy and ocular allergies is seen in patients with keratoconus, and almost 50% of cases of keratoconus in India are associated with VKC. So these patients are very intolerant to RGP lenses. So I'm showing you two studies. In first studies, it was done to evaluate the long-term refractive outcome in patients with cataract and keratoconus after phacoemulsification with toric IOLs. This was a retrospective case series. In this, 54 eyes with keratoconus with cataract were evaluated, and they found that toric IOL showed good predictability in mild to moderate keratoconus, in which the keratometer reading was less than 55 diopters. In the second study, they showed the changes in astigmatism and corneal higher order aberrations after phacoemulsification with toric IOLs in mild KC. It was a prospective case series, and in 19 eyes the study was done, and they had implanted toric IOLs, and they found that after implantation of toric IOL, there was effective reduction in the refractive astigmatism without significant induction of corneal higher order aberrations. So keratoconus patients may have high axial length. So in those cases, we can also use CTR to prevent the IOL rotations. So we have to go for customized toric IOLs because in these patients, the astigmatism will be very high. So correction of higher astigmatism will require customized toric IOL. So this is a small surgical video. Here we can see the implantation of customized toric IOL. So this is a virion-assisted cataract surgery. After removal of the cataract, we can see the markings, which is corresponding to the steeper axis. And in the anterior segment OCT also, we can assess the thicker part of the cornea and the periphery, because that was the safer area for putting the incision. And after implantation of the toric IOL, the axis has to be aligned. So here you can see in the left-hand side, the pentacam reading is showing around 13 diopters of astigmatism. And in the same patient, the biometry also has been done. So here also, almost similar kind of astigmatism is being shown. And after implantation of the toric IOL, in eye trace, we can see there is a significant reduction in the astigmatism. In this image, you can see the left-hand side is the pre-op eye trace. So here it is showing around plus 10 diopter of astigmatism, and after the implantation of the toric IOL, the astigmatism has drastically reduced, and only the residual -3 diopter of astigmatism is present now. So toric IOL cannot be considered in patients who have progressive disease and those who have difficult refraction. And if there is a high difference between pre-op RGP lens corrected visual acuity and spectacle corrected visual acuity, and patients who have advanced keratoconus who may undergo keratoplasty in the future are not the ideal candidates for toric IOLs. So take-home message is that it's a good option if the patient has ocular allergy and if there is no compliance with contact lenses. And if there is socioeconomic limitations and mild to moderate stable keratoconus, toric IOL is a very good option.